Ellie, can you briefly introduce yourself and explain your journey and how you got to where you are now?
Sure, I'd be happy to do that. So, I live in Albuquerque, New Mexico. I went to school at the University of New Mexico. I got my bachelor's in psychology there, thinking I was going to go down that clinical route and then maybe be a counselor. I thought about social work. And then when I learned about OT and how a lot of occupational therapists do work in mental health settings, I decided that sounded like the best fit. So I got my master's at the University of New Mexico also. After that, I completed a fellowship with the VA in San Diego in a psychosocial rehabilitation and recovery clinic. And then when I finished, there was a job posting for the homeless program in Albuquerque at the VA. So I applied for it and I lucked out. And so I got to move back home right away with the job. And I've been here now for almost 5 years in this program.
Oh, nice.
Yeah.
So what is your roles exactly, and what does a typical session look like?
So maybe I'll tell you a little bit first about what the homeless demographic kind of looks like, and then that will make it more clear why we use certain assessments and interventions. So
Mhm.
we have a significant homeless population here in Albuquerque, like we're the biggest city in New Mexico, so like many other big cities, this is where people tend to be if they've lost housing, or sometimes they're passing through. We're a huge state, so they just end up here. The homeless program works with the Housing Authority to manage Section 8 vouchers that have been designated specifically for veterans. So we have case managers, and their job is to help a veteran apply for one of those Section 8 vouchers, find an apartment, move in, and then work with them to make sure they are able to maintain housing, pay their rent, etc. So for OT, my involvement initially began with helping the team to identify who might be an appropriate fit for independent living and who maybe needs a higher level of care, because that's always been a challenge. We have a lot of older veterans. A lot of the people in our programs are 50 plus, 60 plus, and having been on the street for a really long time, a lot of complex health issues that have been unmanaged, unmedicated, untreated. So they're not healthy. They're not well. They've aged roughly. So many times those people, they would not be safe living alone in an apartment physically. Sometimes it's a cognitive issue because the veteran population tends to have a lot more incidents of traumatic brain injury. Of course, there's a lot more PTSD, and in combination with health issues, depression, anxiety, suicidality, there's just a lot going on for them. So I will often do a functional assessment to see if that person can complete essentially basic living skills, basic IADLs, such as being able to pay their rent and explain how they do that, access public transportation or know how to get around, hygiene, self-care, that sort of thing. And that will give us a little bit of a picture of, how well they would do in housing or not. We conform to the Housing First model, which is a harm reduction model. And it essentially says, whereas in the past we used to ask people to go through rehabilitation programs so they could learn job skills and whatever else, and these people would not leave those programs and then go on to attain housing. It's not an effective model. So now housing, employment, substance abuse, they're all better treated using the harm reduction model, which just means do what you can. So what we do is put them in housing and then see how they do. And for a lot of our veterans, that's what they needed. So once they have an apartment, they're able to stop worrying about their day-to-day, and they can then focus on things like getting primary health care and participating in behavioral health care, thinking about getting a job, reconnecting with family. And so if someone looks a little iffy, but we're not totally sure, as long as they're safe transferring, then I usually just recommend let's try it in housing. Let's see how they do, because some completely surprise you. They come in, with very severe schizophrenia, delusional hallucinations, and they get into housing, they get connected to healthcare, they get on an antipsychotic, and then they are perfect. And you're like, I cannot believe this is the same person.
Wow.
And you just kind of have to give them the benefit of the doubt and try housing.
Hmm.
So that's part of the role. Do you have any questions about that piece so far before I keep going?
So what's like the most challenging conditions or situations you have had while working in the VA?
In the VA system in general, or in this
In this
particular clinic?
clinic?
Okay, that's great. I'm sure Deb mentioned it before, but I can't speak, of course, for VHA.
Yeah.
Everything that I say is just my experience and personal opinion.
Yeah.
Let's see. I guess probably the hardest part is identifying housing,
Mm.
low income, accessible housing, because so many of our veterans are older. They need first floor apartments. A lot of times they start using a walker while they're in our program. They might switch to a wheelchair. I have some veterans who have bilateral amputations, and usually what ends up happening is our case managers are pressured to house them. They have a certain number of days before their voucher expires. The veteran is living on the street or staying in the shelter or in one of our partner nonprofit programs. And so they tend to take the first available unit or house them in an apartment complex where we have a lot of veterans living. And then the problem is that I'll come in 2 weeks later when they're referring this person and they're saying, I'm having a lot of pain and I fall a lot. And I'm like, you are in a second floor apartment. And that should have never happened. What happened?
Yeah.
It's that part's pretty stressful. So identifying housing for low income that is accessible is a huge challenge. There are very few
Yeah.
apartments that are, and the ones that are, people are living in them and they don't leave because there's nowhere for them to go. So retroactively trying to modify a unit to make it safer is a lot of the role. Tub benches, grab bars where we can. Sometimes the landlords are willing to do things like take off the bathroom door, take off the closet door, install a temporary ramp. So just kind of whatever we can to make this place they've ended up in as accessible as possible. So just
Yeah.
resources in general, that's hard.
Yeah, I can see, like, I think it would be really stressful and kind of overwhelming, like working with all those people, like trying to work with the home modification specialist and just trying to get that housing the best way possible for them. Yeah.
Mhm. Yeah, it's pretty tricky.
Yeah. So, how do you collaboratively work with the clients and like other health professionals, like physical therapists and any other healthcare professions?
So in our program, we have a primary care team now. It's
Mm.
pretty new. We've only had one for a couple of years. So we have a nurse practitioner and an RN and an LPN. So we are now able to offer those services directly in our clinic. So that's really nice. How I participate on that team is usually somebody comes in, the NP identifies that they need equipment in their home. She orders it, and then I go in to set it up and make sure they know how to use it correctly. That's how we partner generally. Or if one of the case managers comes to me and says, I have a guy who's having a lot of pain. I have an example. Because we're such a big state, we also have veterans living all over the state. So we have guys in Taos and in Gallup and in Hobbs, and they're just kind of out there floating. The social workers come and go in those positions. So there's one gentleman who was complaining that he had just gotten a total knee replacement. He didn't have physical rehab after, because that was right when the pandemic started. Everything shut down. So he didn't get any therapy services, and now he's in a lot of pain. So the social worker tells me about that, and then I contact the nurse prac and say, hey, can we put in an order for this guy to get physical therapy? He's willing to do telehealth. He's willing, whatever it takes, and kind of be that go-between, because the social workers don't necessarily know exactly what might be appropriate for something like that.
Mhm.
And I I try to maintain a good relationship with the primary care providers because I connect with them a lot.
Mm, thank you.
Mm-hmm.
So we see that in San Diego, you participated in the fellowship in psychosocial rehabilitation and oriented services, and you have, it seems like you learned a lot of information and like strategies for working with like different populations and diagnoses like psychosis and other things. Can you just talk about some of the valuable information and strategies you learned during the experience?
Sure, I'd be happy to. That that was a really great experience. I don't know that they have any OT supervising there now. I think they're taking voc rehab therapists at the moment, but there are fellowship spots available in Durham and maybe West Haven. Um, so the reason that that was so cool is that we kind of got lumped in, myself and my co-fellows, who were two psychology postdocs and a social worker, and they just sort of threw us all together with the other psychology postdocs. So we got to participate in all of the seminars. So we learned a lot in general, just about all the different diagnoses, and I got to see really how the psychologists think about working with people, which was really interesting. I think a lot of independence right away. The model that the clinic ran by is, they have residents, so the residents offer the treatment and the staff offers supervision. So I would run 4 or 5 groups a week. I would partner often with the co-fellows or voc rehab therapist. We had a peer support specialist there, and I didn't talk about them earlier when you were asking about collaborating with other professions, but peer support is essentially a veteran who has lived experience of something similar to what's going on in the program. So may have experienced homelessness before, substance use disorder, recovered from a serious mental illness, something like that. So I would partner with them often because they would kind of be somebody who really understands military culture, somebody that the patients trust more than they would trust me because I'm a civilian and I might not understand. And then they would support me to do more community integration, kind of higher level IADL stuff. We would do socialization. We would go out as a community together and do, every week we would go and go to the aquarium, or we would go to the zoo, or, just whatever we could find that was cheap or free. And it was nice because they could really be the kind of like hype girl for the position and get everybody excited. And I would be there sort of creating the structure for it and ensuring that the activity is therapeutic, sort of modeled after a goal-seeking process. So that was really great. Yeah, I think those are probably the things that I value the most from that experience. And then
Okay,
supervision
awesome.
also.
Thank
Yeah.
you.
Yeah.
So me and Mallory, we recognize that we're for OTs working in the homeless population, we notice that there's a lot of societal stigma with the homeless population and OTs working with the homeless population. So what can we do as future OTs to advocate for this emerging practice setting?
So when you say stigma, I think that what I've heard from other OTs as far as working with the homeless population or any kind of community-based behavioral population is just that it's difficult to get into the position because there are so many other mental health clinicians out there. You've got social work, you've got counselors, you have behavioral health specialists, you've got psychology, psychiatry. And so essentially they're like, what, we don't need one more we don't need one more behavioral health clinician. We already have all these other ones. What do you do? And we've been sort of pigeonholed into this ortho model in most of the major hospital settings. So that's really the only thing that I've heard. Most of the therapists that I've talked to, a lot of them being students because I take them on as fieldwork students or whomever, are very interested in mental health and would love to work in this setting. Is that kind of what you meant by
Yeah, because like some people are like they're not sure of mental health, and it's not common, and I'm sure it's hard to find. Like even when I was looking for mental health facilities around my area in Michigan, it was like really hard to find a place
Mhm.
that has OT, and we want to like promote it and um, just try to
Yeah.
like teach others like how OT's role can like make such a big impact, you know?
Yeah. Yeah, it's really challenging, especially if you're kind of cold calling organizations to set up a field work or to see if you can get a job there. Um, I did one of my clinical rotations in Utah. It was with the refugee resettlement program, and the OT that was my supervisor had essentially, she had a full-time job at the university, but she also partnered with multiple local nonprofits in her spare time. So she worked with a clinic for torture survivors. The university had a community center where they provided services for a lot of the refugees that they worked with. Um, there were some other programs like that. So she basically just showed up and said, "Hey, I'm an OT and I would really love to volunteer my time here so I can show you what we do." And then at some point, hopefully get written into their grant so that she could get paid to hold that position. The VA is easier because they, of course, I'm sure you've heard about government benefits and all that. It's a very stable position, and they will, they'll pay OT to do mental health services. But in general, Medicare, we don't really have a way to reimburse for straight mental health services. You kind of have to interweave your services with sensory based or cognitive based, community integration. Yeah, I think that's why it's really challenging, is you can't just go out
Yeah.
there and do it and get paid for it.
Hmm. Yeah.
Yeah.
Along with those barriers and other things, have you encountered any other challenges like ethical dilemmas or like experiences with clients who are don't adhere to therapy?
Yeah, I think I've always really taken issue with that, the concept of non-compliance. And I think, when we say that somebody's being non-compliant, I think we're really just being lazy and saying we don't understand why this person isn't doing what we want them to do. There was a psychologist here who offered a motivational interviewing class, and she used to say, if they decline your brilliance, your brilliant treatment strategy, because you're working so hard with somebody and they don't, it's not working, it's not what they want to do, you're just kind of forcing your clinical opinion on
Yeah.
them, and then getting mad and confused when it doesn't work. So really, the best way to engage with somebody is to find out what they want to do, find out what's meaningful to them, and then you can kind of come at it from that route. But I think that that's in general a challenge when you're working in more of a case management model like this clinic runs by, because it's primarily social workers whose job is to get people housed and then make sure they stay housed. So it's a lot of doing for people and not really teaching people how to do things or doing it with them, unfortunately. And so the kind of like the learned helplessness just stays a problem. And they can be in the program as long as we have funding from HUD. So some people have been in our program for like 10 years and may not have really grown in their skills. I think also the expectation that somebody has to make some changes is challenging, because it's not necessarily the case. If you have somebody who's dealing with severe mental illness and a lot of childhood trauma maybe, and they're just like doing the best they can, they might not ever become more independent than they are right now. They may only be able to participate in housing if they have somebody there to remind them to pay their rent, or help them deal with people because they're really impulsive or they have trouble managing their anger. And that just has to be okay too. And so to say that somebody is being non-compliant because they're not doing what you ask them to do is, again, just, it's not true. It's just it's just lazy. So
Yeah.
sometimes that feels like a little bit of an ethical concern. I'm like, get in there, don't just
Yeah.
get mad at them, get in there. They're not just being a jerk,
Mhm.
they have a mental illness. And then I think just, again, the lack of resources feels ethically very
Yeah.
yucky. It's hard to just tell somebody, they walk in at 3:30 on a Friday and they have no place to go. They have a partner, they have a dog, and the shelters don't take the dogs, and the partner has to go to a separate shelter, and you have nothing to tell them except, I'm so sorry, maybe it would be better for you to sleep outside tonight if you don't feel comfortable in the shelter, because a lot of them don't. There's a lot of reasons not to go to a shelter. That's really hard too.
Yeah.
I have another one to tell somebody who is on the borderline of, being cognitively able to manage themselves that they can't have housing. And then what they do is they just go back on the street. So
Yeah.
you're telling somebody, I'm not going to give you housing. You're just going to have to remain homeless until they present often enough to the hospital and they physically decline enough to the point where they go to a higher level of care. It's kind of yucky.
Wow.
We just don't have intermediate services, though. We don't have group homes for those people that they can afford. We don't have any other options.
Difficult.
Yeah.
Are there any other like specific models or frames of reference that you use with the homeless population? I know you said the housing first model and then the harm reduction model.
Mm-hmm. Definitely. Let's see. So first is definitely, well, the recovery model. Have you guys learned much about the recovery model?
Yes.
Psychosocial rehabilitation. Okay, great.
Mm-hmm.
So I think anytime you're working with somebody in the community who has mental illness, that's the model that you can follow to be the most successful. And that's all about just helping that person kind of reclaim the identity that they had before with the barriers that they're now experiencing. Help them get back into the community, get back to being a father if they want to, or a good partner, getting back to having a job or participating in the hobby they loved, being a musician, whatever it is. That really speaks to the OT concept of helping somebody identify a meaningful activity and participating in it. They're so interconnected for me. So I think that that's a really good one to know. And then just as far as more of the traditional OT models, I really like the PEO model, the person, environment, occupation. I think it just makes sense in my head. You have the person's abilities, what's going on with them physically, what their diagnoses are. You have where they're going to be, if it's their apartment, if they're on the street, if they're in the hospital, whatever. And then you have what they're trying to do, of course. Cook, get in the shower. So that's probably the easiest one.
Yeah. So do you have any other like advice for working with the homeless population, and really like why should entry-level OTs pursue this setting?
I think it teaches you a lot about how, if you just try to push your clinical opinion on somebody, you are going to be spinning your wheels. And I think, conceptually we know that you can't make somebody do something they don't want to do, but until you actually try to get somebody, to quit smoking or to pay their rent so they're not homeless, you almost can't understand the frustration that it is, which teaches you, how to make sure that you are eliciting realistic and meaningful goals from your clients. So if someone's not, doesn't seem to care about managing their money or paying their rent on time, but it is really important to them to be able to see their grandchildren, maybe they are motivated to pay their rent because they need a place for their grandchildren to come and see them. And that's a different way that you can kind of attack that. I think learning more about goal setting in terms of motivational interviewing and, how to kind of work with somebody who might kind of know that something's bad for them, like quitting smoking is probably the most generic example for motivational interviewing. And, we know it's not healthy. We want them to quit. We know it's raising their blood pressure and they have COPD and, all this other stuff going on, but they haven't put those two things together. So having conversations with them so that you can kind of elicit some feelings about smoking and what they might experience. Obviously what's the function of the behavior? Why are they doing it? Why is it good to smoke? Because if you don't understand that, then you're just going to be like, they're not compliant. You're not going to get anywhere with them. So understand why it's working for them, and then, maybe try to attack it from something else that's meaningful to them. And you can apply that in so many different ways. I I think that's probably my biggest one. I don't want you to run out of time and then us to get caught up. So
Yeah, no, thank you. We really appreciate all this information.
mm-hmm.
Mallory, do you have any questions?
I kind of have a random one going back to the mental health psychology part that we were talking about. I also have an undergrad degree in psychology, and I've always had people ask, why are you going into OT with a psych degree? I guess, what would you say has helped you with that, and how would you answer those people?
It's so interesting because my experience was completely the opposite. I didn't know that OT was sort of traditionally ortho like it is now. I didn't know that. When I started doing volunteer hours, I worked with a woman who specializes in assistant animal interventions. So she worked a lot with adults who had developmental disabilities and kiddos who have autism. And that's what I saw. And I did a summer camp for kids with autism. And so until I started collecting more hours and ended up following somebody at an outpatient ortho, and I was like, oh, this is, I'd never seen that. So it totally seems to depend on the culture that you get involved in when you're getting into OT. But I think that, the way we kind of think about doctors and that they don't necessarily always prioritize mental health when they're looking at the body, I would say that that's a similar frame for me. If somebody's saying, why do you need to understand mental health? Because the person with schizophrenia is still going to break a hip and go into the hospital. And so you're going to have to work with that person. And if you don't understand how that affects their ability to understand and learn and, the likelihood that they're going to be able to rehabilitate or, modifications you might have to make to your teaching style to them to make it effective, you're not going to be an effective therapist. It's just not going to happen. So we are one whole piece. We're holistic. You cannot just treat somebody's body part. I think that's a big part of it. But as far as occupation, we're looking at everybody at all ages participating in all kinds of activities. And so to say, we're just doing adult hands or something it just doesn't make sense. If you're talking about meaningful activity, you're talking about that for everybody, all ages, mental health, physical health, sensory stuff. So that's tough. That's a soapbox.
Thank you. Yeah.
Okay, you guys. We're running out of time, so I just want to say thank you so much for meeting with us and talking to us, Sally.
You're welcome. And if you have any more questions, I'm happy to chat again. Definitely available. I hope everything goes well for you the rest of your semester and that you're able to find a job you're really passionate about.
Yes.
Yeah.
Thank you.
You're welcome.